everybody. Thanks for being here. My name is Nuzi Barkatally. I'm a VP here at Silicon Valley Bank. I cover early stage founders on the healthcare and tech side. My background is as an operator working at various startups. So basically, I've gone from building to banking, which makes me excited because we're going to talk about building today. Sitting next to me, we have Colby Takeda, the CEO of Pear Suite. Woo! Yeah. Pear Suite is a digital health platform that empowers community health workers and addresses social drivers of health. Colby got his start in public health back in Hawaii, where you worked on prevention campaigns for underserved communities. Then went on to become an executive and administrator, opening up senior living facilities across the state of Hawaii. Along the way, you've gotten an MBA from the University of Hawaii. You've gotten a Master of Public Health from Berkeley. And I think you were working on your doctorate at some point. You still working on it?
I am.
Okay.
Secretly.
Okay. While you start a company, while you grow a company. And fun fact, Colby and I know each other from a few years ago. How do we know each other, Colby?
Yeah, so we participated in the Techstars LA program, and Nuzi was one of our mentors and helped out with some of our early stages. This is when we first started the company, very early, young Pear Suite.
Yeah, no, it's pretty amazing because I've basically seen you go from having barely like a couple customers to now 100 customers across 25 states. Which is amazing, and that's only been in a few years. So to kick things off, let's take it back to the beginning. What made you decide to start Pear Suite?
Yeah, thanks so much, Nuzi, for having me, and thanks for SVB for sponsoring this. We really are passionate about community-based organizations. These are your nonprofits, your community organizations that are working at community events or churches or at grocery stores, helping people navigate SNAP benefits. Outreach organizations supporting LGBTQ organizations or working in public housing, supporting different languages or immigration status. These are nonprofits that are doing amazing work. And for the longest time, they weren't being paid. They weren't being paid by the healthcare system for helping with this navigation, helping with screening. And we knew that we wanted to change that, which is why we started Pear Suite. We wanted to support nonprofits to better partner with health plans and providers.
Okay. So where did the idea come from?
Yeah, so the pandemic, of course, opened up the eyes to the world of the power of these on-the-ground nonprofits and groups doing work around navigation, screening. Those are the ones that are going door to door, get people vaccinated. They were helping to spread the word around the importance of vaccination and screening. They were helping people navigate loneliness and isolation, helping them with food insecurity or housing insecurity. And we just recognize that they're so valuable. The relationships really matter. And we love that they're so useful and helpful. They use their lived experience to provide care and support for those who are underserved and unhoused sometimes, people that are lonely in their homes. And we knew that the healthcare system was benefiting, but not paying them and compensating them and valuing their work appropriately. So we started off doing work during the pandemic and ended up building software for these groups to get paid by the healthcare system.
Yeah, so tell me more about this, because I think when we first met, I also wasn't sure, like, how has this become like a VC backable business? Because, I mean, with the tech part of it is very backwards on that side. So explain to me how this becomes an actual product. How do you operationalize community health workers?
Yeah, so community health workers were actually been around for decades, and for the most part of the century, doing things on grants and getting nonprofit funding. But now there's actually reimbursement codes through Medicaid. Policy change has allowed for reimbursement to be possible for these groups to get support and funding through fee-for-service reimbursement. 30 states or so have codes now to allow them to get paid on an hourly or half an hour basis. Medicare actually approved through CMS reimbursement as well, and this has allowed these organizations and these providers to now get compensated. So it's been a policy shift. It's been new data out there around the effectiveness and community health workers. Of course, COVID funding that came during the pandemic to support workforce development and training of community health workers. So all these kind of positive things happening have allowed us to really grow and expand, and the timing was just perfect.
Yeah. So what have been some of the biggest challenges you've faced in terms of building a product and an experience for both community health workers and who you're selling to in terms of the payers?
Absolutely. I'm just curious. Does anybody know what a community health worker is? Have you guys
That's a good idea. We should
worked
start
with
there.
community health workers? Oh, okay. Well, maybe we should. So think about, the nonprofit organizations that have outreach workers who maybe are doing education at community events, or maybe they're hosting cooking classes and talking about nutrition and how to, buy good food. They might be helping you fill out your application for housing registration to get, HUD housing, for example. These are people that don't have clinical licensure. They don't have necessarily high degrees of education. They really focused on their lived experience, many of which have been houseless or using community resources or entitlement programs themselves. They take that experience and go out there and provide this support. Given that, they aren't required to document on any fancy EHR or systems, so they're not necessarily the most tech literate. Some of them certainly are, but not everyone is customized to or accustomed to working in HIPAA compliant settings where there's a lot of regulation and rules and compliance. They have never done an audit before, and so our challenge is how do we build software and technology for tech illiterate populations. A lot of these groups are on paper and spreadsheets or documenting in their notepads and going in the community and doing really good work, but never documenting the work they're doing through care plans or assessments, or certainly haven't billed before. And so our challenge is how do we help them become contracted with the health plans? How do we help them become providers that can provide eligible services and understand what the policy means for them to get paid for this work? And then how do we scale this across such a wide range of organizations? So just to give you an example, we have small nonprofits that have 2 or 3 team members total. We have barbershops doing reimbursable services now because they're providing screenings for men who get their haircut. We help organizations that work in schools provide childcare services for children around things like screenings for vision or helping them get topical varnishes for their teeth. And what a great way to connect with the parents. And so wide range of organizations, their literacy levels around information around the policy is very variable. And so helping them understand the policy, helping them actually do the work and get paid has been a big challenge for us. But that's why it's hard work, it's good work, and I think we've been so valuable because we've actually been able to crack the nut on how to do this.
Yeah. And so from the payer side, tell me more about that in terms of where they see the value in what you're building.
I think payers are recognizing, one, the power of community health workers, right? Mm-hmm. These are relationship first, culturally sensitive. They understand the local resources. They sometimes are really scalable because they're already in the community. You don't have to go and recruit them and train them and really upskill them. How do we now translate that to some of the measures that health plans really care about? These could be quality scores and HEDIS and stars. It could be getting someone just to find out a good doctor that they trust. Helping them overcome their social challenges, right? Going to the doctor could be challenged by housing insecurity, right? Not getting food for your dinner and feeding your family, not having transportation. Mm-hmm. And so community health workers are amazing at solving for those challenges. Once you solve for those challenges, then they can go and get their screenings done. Then they can get their annual wellness visits. Then they can get their, colorectal cancer screenings or their flu shots. And so we just kind of help overcome those challenges with a workforce that's ready and capable to do this work.
Yeah. Okay. So we've kind of gotten to all aspects of where you see the value. Tell us about how you got your first customer.
Yeah. So my background is in these nonprofits. We're working at community-based organizations, and I know that they're ready for change. They want to grow and innovate and be, forward-thinking. We actually got our first customers as nonprofits, community groups that I used to work with in Hawaii, that I built relationships with, and I knew were still on paper and spreadsheets. It was funny, they were actually asking us to teach them how to use Google spreadsheets. Uh-huh. And that was our first kind of customers because we didn't have software back then. And so being able to build for them and partner with them and get data with them early on, build their trust, allowed us to then scale to work with more customers that they were partnering with. The state had some funding to support COVID outreach, so we got some early customers through that funding. Mm-hmm. And then it was building software that can actually scale across the country. And so we built a platform and started building it in 2022 when we met my co-founder, Nick. And since then, we've been able to build a software system that allows for custom screenings, allows for case management planning, allows them to text in and call their patients or clients, and then actually bill for those services, get paid and compensated for that work.
Yeah, that's super interesting. I mean, it's really cool to see where you've proven there's value, I think, because I think initially it's hard for anybody to understand how do you capture that value? Because I think you can understand that community health workers are valuable, But I think the biggest thing is, how do you operationalize that? How do you how do like payers kind of cover that?
Yeah.
So tell us a little bit more about the data side of things, and like, what aspects of the data are you collecting? What are you using? How is it beneficial? What are you building on that side?
Yeah, data is super important. Social determinants of health data. A lot of plans actually have some of this data. They don't know how to use it yet, though. That's the interesting thing, right? They might collect it through surveys. They collect it through what they call the health risk assessment, HRAs. But being able to act on that is a big problem, right? How do you solve for food insecurity if you don't know what the food insecurity problem is caused by, right? Are somebody food insecure because they don't have a place to cook the food? They don't have groceries to cook? They don't know how to, or cook it themselves. They don't have time to cook because they have other challenges or other commitments like working or taking care of family and friends. There's so many different barriers that could cause food insecurity that you'll get if you build that relationship and understand their deep needs. Community health workers are the ones that do that investigative, questioning to understand what is the real core problem of this individual. How do I then solve it with a culturally sensitive approach and solution? And then how do you use that data to show improvements over time with food insecurity? So we collect baseline data around social needs. We show progress measures to see how we're improving on those measures. And of course, we can tie it back to health outcomes. Does this actually reduce the amount of emergency visits? Do we actually increase the vaccination rates? Are we actually reducing the amount of cost of care in the hospital? And if all that can pan out, then health plans are very, very excited. And we've been able to prove that with now 18 health plans.
That's amazing. So tell us more about how you continue to see yourself growing as a company. What's next? Where are you going?
Yeah, as much as we have great software, and I think our software is great, we didn't want to be another tech company. Just tech itself isn't going to solve the problems. We knew we had to provide the extra support, the care navigation, the assistance on things like credentialing. How does one become credentialed to provide community healthcare services? How do you manage claims and eligibility for a member? How do you support with audits and quality assurance? Clinical review. These are all things that community-based organizations don't have. We've been able to build out a team to support in those areas and kind of act as like an MSO. We built a network of providers now, close to 800 providers. We provide them supervision for their clinical claims. We provide our NPI so they can bill through our support. We provided this great provider network of support that allows them to then scale with other health plans to work with providers in the area. And that great capacity to support more members is what the health plans really care about. They want to know that they can provide the quality care through an organization like Pear Suite and support more members through this network. And so we've been able to build this provider network and be able to work on projects like closing HEDIS gaps and STARS, closing other challenges around social determinants of health, and now hopefully scaling that to more states. We're now, like I said, in 25 states, but hoping to grow in new emerging markets like Colorado, where the policy is going to be passed next year to allow for reimbursement for community health workers. We're also doing a lot of work with doulas. Doulas are another frontline public health worker who we're challenged with billing and coding and claims, and we're able to support them as well. So we have about 40 doulas or so on board now.
Wow.
And so really growing in different areas that other are also challenged by these challenges.
Okay. So in terms of measurement and impact, we've kind of touched on that, but for the policy side of things, where do you see things going? Well, what do you feel like is still missing on that side?
So every state's very different, right? Some states require credentialing through the state agency. Others require that you just show you have experience. Sometimes the rates are really, really high, so you can get paid pretty well. Other times they're quite low. And so how do we create some consistency and ease for these organizations to onboard as credentialed providers? How do we help them understand the policy easier so there's no hurdles like pre-authorization for services? Or how do we reduce barriers around limits on services provided? Hopefully we can see some kind of universal licensure process across the state, maybe some kind of certification for community health workers. That's exciting. I think the investment in training is also really necessary. So how do we continue to put money into workforce development programs? Love to see more exciting partnerships across plans, providers, and payers, plans, providers, and the community organizations. That collaboration, that person-centered care, that team-based approach is so key. But of course, how do organizations work in different settings on different systems is a challenge. So how do we integrate data better? Sharing data is going to be key in the future on how do we coordinate care. And so I think finding opportunities to prove that out now with some of our early customers has been really key to our success.
Yeah. So tell us a little bit about some of those strategic partnerships you've had, both on the customer side and also on the community health side.
Yeah, definitely want to call out some of our health plan partners.
Yeah.
Centene in California, HealthNet, Dr. Mittal has been a big champion for us. They made an investment into Pear Suite as a company. Since working with them early this year, we've been able to onboard about 300 providers from the community who are doing this work already and now getting paid for their work. We've been able to then activate those providers to work on projects around HEDIS scores, around colorectal cancer screening, breast cancer screening, asthma remediation programs, helping with tobacco cessation programs. I think those alignment between health plan and providers, us on the ground, has showed us really what the potential of this partnership could look like, but also how do we avoid missteps around the communication challenges across these different entities? How do we share data better so we can actually coordinate care appropriately? How do we appropriately value and compensate these providers? Because it may not be enough to get fee-for-service reimbursement. Maybe we have to add a little more incentive for these groups to partner with the health plans.
Yeah, that makes sense. On the individual side, are you able to share a couple of stories about some of the community health workers that you've worked with?
Yeah, community health workers are truly amazing. I met an individual named Joel Calderon. Joel Calderon, he spent 20 years incarceration, was in a prison and learned about community health work and decided to do a training. Upon being released, he went out there and became a community health worker himself. Later became a teacher, instructor of community health worker programs. Now inspires and leads teams of community health workers to go out and help their neighbors and friends, to help them stay on track and support their social needs. And now he is a co-author of a book around community health workers. So truly amazing to see people that take their experience, their lived experience, their connections to the community, their passion for service and helping others, and go out there and make a difference. So one doctor once told me that if you really want to help the Medicaid population, we have to get them jobs, employ them, support them with things that can help their income and growth potential. And I think community health workers is the perfect position for them, right?
Yeah.
You don't need a college degree. You don't even need a high school diploma to be a community health worker.
Okay.
In California, you don't have to even be a citizen of the U.S. to get paid for this work.
Wow.
And so how do we give jobs and good pay to people that have great experiences and can help those around them for things that they're already doing?
Yeah, and give jobs so they can help their own communities where they're coming from. Tell us a little bit about, in terms of like the credentialing, what's coming in terms of, aligning that across all community health workers.
Yeah, there's a lot of, certainly every position in the healthcare system has gone through this before, right? What's the minimum requirements? What's the credentials that you might need to become a provider? And other provider types are obviously, mindful of what's happening. How does this support or potentially conflict with social workers doing this work, right?
Yeah.
How do case managers kind of manage their workflow while also partnering with community health workers?
Yeah,
so
what's the difference between them?
I think, it's always a question. So I think people are, somewhat mindful of the competitive nature between these provider types. At the same time, I understand the health plans want to set some standards around what training and requirements around understanding of compliance, of HIPAA, around how to properly support in a person-centered way these members. So they have some set standards that they have created. It's called the core competencies of community health workers. Most training programs incorporate the core competencies. But beyond that, I think it's great to see states recognize that lived experience and that work is actually really valuable and not necessarily as important as education and clinical licensure. So it's great to see Joe Calderon, that CHW, says that education is great, but lived experience can't be bought or taught.
Yeah.
And it really speaks to what community health workers provide and bring to the table.
Yeah, that gives me chills. Yeah. Okay, so tell us about how do you build a company that balances both margin and mission? Because you're clearly mission driven, but you're also VC backed. So what is that like?
Yeah, we're really lucky to receive funding to support our company. I like to tell people all the time, we have a good balance between a third of our funders are impact investors, really focused on serving underserved communities and the impact that we're creating. A third are SaaS investors, so they bring that perspective of how do we build a scalable company through our software. And a third are healthcare investors. They understand that these long sales cycles for working with health plans and making a scalable business with the health systems is really, really important. So I think it keeps us straight and focused on what's really important for this population. We're seeing a lot more investment in Medicaid populations and solutions for the Medicaid population, which previously wasn't investable. We are constantly thinking about who are our customers and what do they needs. We aren't building for sophisticated health systems with IT teams that have lots of money. We're building for mom and pop nonprofits that sometimes want to do in-person trainings. They can't use Zoom, right? They want to understand what the challenges are before they commit to this, because technology for them is somewhat, a scary thing. And so focusing on what's the important things, what's the pain points for our customers, really building engineering functions and features for them, and then focusing on how do we then scale that value with people that actually have the money to pay for it. So we've been able to successfully, leverage and really support and uplift the work of community health workers, convince a lot of health systems to pay us lots of money for it, and then actually cover and subsidize the costs for our community-based organizations. So they're not paying all the time for our software. Sometimes it's sponsored by a health plan or health system, which is really valuable. And a health system and health plans should pay for it.
Yeah. I mean, you've kind of basically helped kind of create like a little bit of a marketplace in a way. So tell us about how you got to that, maybe like some of the failed attempts and figuring that out.
Yeah, certainly. Some of these organizations they've been jaded by the healthcare system. They aren't, familiar with how to work with these plans that, may have long sales cycles or might have intense contracting or legal requirements to work with them. I think we'd be able to build that trust with them. I mean, a lot of these health plans came to us and said, we don't know where to find these groups. We don't know what they do, how they operate, how to communicate with them. And so we, in our background as community health workers or people that worked from the community or in the community, was really that liaison to these groups. We listened to them, we asked them lots of questions, we understood them at the ground level, we showed up to their events and worked alongside them and volunteered with them. They really shared a lot about their experiences with health systems, health plans, and the missteps, the things that have gone well, how do we better build partnership across these different groups. And because of that, it really gained trust in us to do this work for them. So we learned a lot along the way, but certainly there's been challenges around, what's the communication challenges with working across groups that may not have good access to internet. Right? How do we support organizations that are really, do really good work but weren't being paid for many, many years, and we're just relying on grants?
Wow. It sounds like trust is a big aspect with this, both with the communities that they're serving and from the community health workers to who they're working with, the partners and the payers as well. Can you tell us a little bit more about the design and the experience, how you're thinking about, what's your future vision for what you're creating?
Yeah, that was a really good question. Future vision, the community continues to drive our engineering build. We heard a lot about organizations saying we can't bring a computer into someone's home. We can't, pull it up and get the internet. So we've actually built out a mobile app for them to actually do assessments and screenings and care planning on their phone in the community, either at events or in someone's home doing a home visit. We continue to think about how AI can support community health workers and uplift them, not take away their jobs, right? Support them and make things easier around documentation, around doing deliverable analysis and doing screenings. We continue to think about what training and support they need to become more effective and efficient in their time. And so kind of embedding that credentialing and that training process into our platform has been a big focus of ours. Also helping them find new jobs, right? Sometimes they're not a good fit for their current organization. Could our network of providers and employers and health systems provide pathways for careers for these individuals and help them find the right fit for their job? And of course, providing opportunity for entrepreneurship. A lot of community health workers and doulas love to create their own organizations and do this work outside of their day job. Through Pear Suite, they can do that.
Oh, that's cool. Yeah. So that you can be supportive of them building their own businesses and still work with them to help the community. Absolutely. That's really cool. Okay, so to kind of close things off, final question. What advice would you give to other founders that are either looking to build both a balance between mission and margin in terms of their company, and or are looking to kind of build in this space? What else needs to happen?
Yeah, I really think, even to this day, we have 40 employees in our company. I continue to go out in the community and do the work myself. I was just visiting some homes last week, doing some home visits. And I myself was figuring out how to do this, and I'm not the expert, but listening to customers, listening to clients, hearing their stories, what challenges they had. I've been someone's home, and I had to work through a child who was translating for their mother. Right, these are real challenges that we face, and how do we help as a community health worker to make these interactions and these engagements better. I continue to listen to our users. I love visiting them and seeing them in the community when they have events and using our software at community events, for example. I love going there and supporting them, bringing them donuts, seeing how they like the system, asking about feedback. You learn a lot by seeing it in action, and so continue to be involved, being on the ground. I think regardless of how big your company is, CEOs should be embedded in the operations of the organization and to really see and hear from the frontline workers. I think that's allowed us to really grow and really focus on what is our key differentiators between other systems, but also how do we prioritize builds in the future? How do we make our engineering roadmap align with the needs of our customer?
Yeah.
And of course, how does that all work with our health plan partners as well? And so talking to health plans a lot of time, asking them questions, getting the insights from different people that are smarter and wiser than us, and really using that to drive our future.
Okay, awesome. I just wanted to kind of throw it to the audience if there's any questions. We can keep going. We still have lots of time. What else can we talk about? That health equity side? How are you thinking about that, in terms of making sure you're actually seeing outcomes in health equity?
Yeah, it's interesting. People always ask us, we could work with the best and brightest nonprofits out there, but what about the smaller ones? What about those two-person nonprofits that may not have the capacity or the skills to do this on their own? We sometimes work with groups that can't afford our subscription costs, and so we love giving discounts. People always say if they want to get a discount, talk to Colby because he has a big heart and he'll just give you free software.
You do have a big heart, yeah.
So I always hear people mention that on the side, but yeah, I think there's a lot of value in the groups that we work with, and regardless of how big or how technically savvy they are, everyone has an important role to play in our ecosystem, and if we can uplift them and empower them to do more, we can win. And I think if this was easy for these groups, other companies would be doing it already. So I think health plans appreciate our extra effort to onboard the hardest to reach, the people working in remote areas, these small nonprofits.
Yeah, I agree. I think where you're building in terms of all things, it is very hard. Healthcare in general is very hard to build in, but with where you're building, it's the hardest. It's not clear. It's kind of messy. There's people doing really good work, but the tech is very behind. Payers can't really use it. But you guys have done the really hard work. You've kind of gone out into the communities. I think sometimes when people build companies, they forget that sometimes you can't just stay behind a computer screen. You have to actually go out and build. So you guys have done that.
And it's great. I just want to shout out two of our employees here, Andrew and Stefan. Both of them, did a lot of work in the community with nonprofits and healthcare, but they themselves enrolled in a community health worker program and are training right now to become community health workers.
Oh, that's so cool.
To better understand the market and understand what it takes to become a frontline public health worker. And actually a lot of our employees as well. So one engineer went through a program.
Having them
we have
all
a lot
understand
of
that.
team members that have gone. And we hired big tech employees before. It didn't work out because they're used to working with sophisticated IT departments, not necessarily working with the community, and that makes a big difference.
Yeah. Well, it's amazing what you're doing. Thank you for sitting down and chatting. I always love chatting with you. It's so good.
Thanks, Nuzi, for having me. And it's always great to talk to you.
Yeah. Thanks, Colby.